Hello, I'm Michel Arcand. I'm one of the orthopedic surgeons here at University Orthopedics. I'm in the sports medicine department. I specialize mostly in shoulder and elbow. I'm a native Rhode Islander. My topic tonight is shoulder arthroplasty. This is a way that we can help people with painful shoulders return to pain-free function. The words shoulder arthroplasty mean that we're going to reconstruct the glenohumeral joint. There are several different ways to do this. So the purpose of this talk is to define what shoulder arthroplasty is, discuss the different types of arthroplasty, and show some examples of shoulder arthroplasties. So the types of shoulder arthroplasty. So basically a total shoulder arthroplasty, what it means is that we're going to reconstruct both sides of the joint. So we're going to put an implant into the glenoid socket as well as put an implant onto the ball. The two most common types of total shoulder arthroplasty are the anatomical, which is seen down in this picture, where we put a metal ball where the bony ball used to be, and then what we can't see is that there's a plastic socket put into the patient's normal bony socket, and the two together are the reconstructed glenohumeral joint, which just means shoulder joint, and that's a total shoulder arthroplasty. On the example above it, we have what we call a reverse shoulder arthroplasty. In this case, we've taken a ball or a glenosphere and we've placed it into the socket, and we've put a socket that we can kind of see onto the humerus, and this articulation is the new shoulder joint. There's a third type of total shoulder arthroplasty, which is usually is an anatomical type, where we're going to put a ball onto the humerus, and we're going to treat the glenoid or the socket and with either some resection, or some people can put a piece of tissue over to kind of reconstruct and try to form a new joint surface on the socket. There are reasons to do this, especially in young, active people that want to continue doing heavy lifting or have jobs that are physically demanding. There's what we call a hemiarthroplasty, which is just replacing a part of the joint, and this is usually just the side of the ball. We usually do not touch the socket. And then there's what's called a resection arthroplasty. In a resection arthroplasty, the ball is being usually cut out if there is a implant that had been placed into the socket. Usually that is removed, and what is left is a area of scar tissue that's going to form between these two components, or where the components used to be. That's going to be the new joint. Sometimes if there's not enough bone left after failed surgeries, this can be a good salvage. It allows some motion. It's not very strong, but if a patient's had several infections, this could be something that may allow some pain relief, but the lack of further options is the reason that it's called a resection arthroplasty, is because we can't really do anything else, but some people tolerate this fairly well in a low demand situation. So a total shoulder arthroplasty, like I just said, we're replacing both sides of the joint. And here's a diagram that shows clearly this is the glenoid component. This is a new plastic socket that's put into the socket. And there's a metal ball that's used to replace the ball that was normally seen there. There's all kinds of ways of fixing this ball into the humerus. And this is an early example of how we used to put a long metal stem into the bone to hold the ball into position. The reason I put this slide in is because there's a difference between an anatomical and a reverse. So A reverse is a non-anatomical reconstruction, and all that means is that we're going to place a ball in the socket. So we're going to put the opposite or the reverse of what we normally see in with the reverse. The anatomical is it's what the anatomy was before. So we're going to take our components and try to mimic what was there before. The advantage of the reverse is that it allows us to reconstruct the shoulder joint even if there's a very large rotator cuff tip. In a regular anatomical shoulder arthroplasty, the shoulder is very dependent on the rotator cuff to rotate the ball in the socket and to hold the ball in the socket appropriately. If there's a large tear, the deltoid pistons the ball up and down in the socket because the rotator cuff cannot hold it into position, and this will loosen an anatomical replacement and sometimes will prevent the patient from being able to lift their arm. And when that happens, the reverse puts a ball in a position that you cannot piston. And when the deltoid contracts, since you cannot piston, you will rotate the ball around, or the socket around the ball, and that will provide good motion and good pain relief. So total shoulder arthroplasty, it can have different looks. So both of these are total shoulders. One of them has a stemmed implant. The other one has a stemless. The difference between the two is very obvious on the screen. You can see the long stem. We used to use long stems like this to kind of hold the implant into the bone. What we found is because there's a metal implant, it can weaken the bone and cause some bone loss, and it can make it more difficult to reconstruct if ever this fails. So the push in orthopedics, not just for the shoulder, but also for hips, has been to try to decrease the size of the stems and the implants in the bone so that we get less what we can call stress shielding, loss of bone because the metal is taking up some of the stress, and trying to preserve bone and allowing maybe a revision to have a shorter stem, not even maybe necessarily using this long a stem if we had to revise this component. So we're trying to, as we get better at treating these conditions and we're better at making implants, we're trying to preserve as much bone as possible in case people need further reconstructions down the road. The reverse, this is what it looks like on an x-ray. This is what it looks like when you take the components apart. So we have the metal ball. It's usually mounted on a plate, which we call the base plate. These base plates are screwed into the native socket after we kind of remove any residual cartilage or joint surface and try to get some bleeding bone, because most of these have bone ingrowth along the back. We then attach a ball to the base plate, and then on the humerus, we remove the head, kind of put our stem and socket in, metal socket into position, and put a plastic socket between them. And this is the new articulation, is between the plastic and the metal ball. And like I said, this prevents pistoning with an absent rotator cuff and allows the arm to lift even if there's no socket. Even if there's no rotator cuff present. So the Ream and Run is another procedure that's gaining in popularity. It's mostly for younger active males that are doing either physically demanding jobs or like to or don't want to give up going to the gym and lifting weights. What we're doing on this is we're basically cutting the ball off, reconstructing the ball with a metal implant, and then we're kind of reaming out the socket. So we're taking some of the remaining joint surface and we're making the socket smooth again. We're causing some bleeding there that will hopefully form a scar joint surface that can give us some added time before it completely becomes painful and wears out, but hopefully could get somebody back to a heavy lifting job, back to weightlifting without the downside of loosening the socket. In general, the weak point of a total shoulder arthroplasty is the socket. So this is a way to try to avoid this. And it seems to be improving a lot of people's pain. So the hemiarthroplasty, these are when we are only reconstructing one side of the joint. There's, again, different types. They can be stemmed and non-stemmed. Here's just an example of a non-stemmed one. We usually use this if, like, the diseased portion of the joint is just on the head. So in this patient, they had what was called an avascular necrosis, where the blood supply to the ball was impacted and the ball was starting to collapse. It did not collapse enough to cause any wear on the socket. And in a younger patient, this is a good option to try to preserve the time before that the patient would need to do a revision. And at one point, if the shoulder does become painful, we might just be able to put in a plastic socket and get a total shoulder arthroplasty that will be helpful. Over here is an example of a patient that had an infection where we had to remove the components. This hemiarthroplasty, because it's just on one side of the joint, actually leaches out antibiotics and helps combat the infection. Some patients actually feel good and have good function with one of these, and I have had to, or patients have told me that they would prefer to just have this instead of reconstructing the joint with another metal implant. So, but this is definitely one of the types of replacements that we do. Here's an example of a resection arthroplasty where there's not a lot of bone, so there's not a lot of other options. In trying to reconstruct this with grafts or metal could just re-aggravate the infection. This was giving this low-demand patient enough pain relief and function that it was felt that this is all that they want. So why do we perform shoulder arthroplasties? Well, one of the most common problems that we see are rotator cuff disease. Rotator cuff disease is tendonitis, tearing of the tendon. As this progresses, some patients develop large rotator cuff tears and arthritis, and we can use a reverse shoulder arthroplasty to try to improve their function and their pain. There's all kinds of arthritis. There's osteoarthritis, which is normal wear and tear arthritis. These usually do well with an anatomical type of total shoulder arthroplasty. There's inflammatory arthritis, like rheumatoid arthritis, where our body is actually making antibodies that are attacking our own joints. In this case, especially in the shoulder joint, this affects not only the joint surface, but it can also affect the rotator cuff. So in some patients with inflammatory arthritis, we are doing a reverse shoulder arthroplasty because of the damage being caused to the rotator cuff. Post-traumatic arthritis can be treated sometimes with either reverse or anatomical shoulders arthroplasty, depending on where or what the condition looks like. But a lot of people with post-traumatic arthritis will either abnormally wear out the socket or will have, like, the avascular necrosis that collapses the head and requires something to try to make them better, improve their pain or decrease their pain, and try to improve their function. Sometimes, especially in the older populations, fractures and dislocations can be treated with, usually the implant is a reverse shoulder arthroplasty. So bad fractures where the We cannot like put the pieces back together, or if the blood supply to the articular surface or the bearing surface is interrupted, we will do, usually it's a reverse shoulder arthroplasty for that. The same thing for instability, where the patient is dislocating all the time or staying dislocated. In the older populations, some of this is because of bone loss, and trying to replace that bone loss with a metal implant is sometimes the best option. On revision surgeries, so let's say that somebody has failed an arthroplasty, or sometimes failed rotator cuff repairs, we sometimes go to arthroplasty, especially reverses, to try to get the patient back to function, get rid of their pain, and these do very well. So the reverse shoulder arthroplasty, it's the most commonly performed total shoulder arthroplasty. We substitute for the loss of the rotator cuff by preventing that pistoning, that contraction of just the deltoid will cause inside the ball and socket joint. As I mentioned, it's helpful for inflammatory arthritis, because a lot of times the cuff is also being attacked as well as the joint surface. So you are having problems with your rotator cuff, so you might be safer substituting for the rotator cuff and then reconstructing the joint in a way to relieve pain and improve function. Fractures are usually treated with reverse shoulder arthroplasty in very severe cases where we do not think that we can either put the pieces back together in an anatomical manner, or if we think that the damage is so severe that the articular surface will lose its blood supply. In that case, even if we put everything back together, it would lead to an osteoarthritis, and the patient would have to undergo 2 surgeries instead of 1. And we know that people do better with 1 surgery instead of having multiple surgeries. So that's why it's very useful in some types of fractures. And the reverse shoulder arthroplasty is kind of the workhorse for revision surgery, whether you have an anatomical in there to start or a reverse. Our bailout is usually to revise it to a reverse. It also is used in failed rotator cuff repairs, and a lot of the failed fractures also are usually easier to reconstruct with a reverse shoulder arthroplasty. And like we've already mentioned, this is a non-anatomical reconstruction, and all that means is that it's not what was normally in there or what God gave us. This is a way to try to return function, decrease pain by changing the forces in the shoulder to still give us a good reconstruction. It is deltoid powered, which means that your deltoid has to work for it to be successful, especially to lift the arm. If you do not have a good deltoid, there are surgeries that can be performed now to try to substitute the deltoid with another muscle. But if you have a non-functional deltoid, you're less a good candidate for a reverse shoulder arthroplasty. The incidence of, or the frequency that we're doing reverse shoulder arthroplasties is increasing. We also use the reverse in osteoarthritis, sometimes in patients with a lot of deformity. The base plate is smaller than an anatomical glenoid and or socket component, and that allows us to place it in there even if we've had some fairly severe bone loss. Some people with very large rotator cuff tears can have what we call a pseudoparalysis, where the deltoid and the remaining rotator cuff cannot actually lift the arm. In that case, the reverse can use the deltoid and that remaining cuff to lift the arm. So it's one of the few times that patients with maybe not a lot of pain but just loss of function can be improved with a replacement. Rotator cuff tear arthropathy is kind of what we see in this picture over here, and that is a degeneration of the joint. It can sometimes, you can see that the head is no longer in the proper position in the socket, and that can be very difficult to reconstruct using an anatomical replacement. And if that was to be done, it would loosen prematurely. So degeneration with big rotator cuff tears are a good indication to have a reverse shoulder arthroplasty. The fractures, the four-part fracture usually means that we think that the articular surface is devascularized, and a reverse is helpful for that. And we've already talked about the revision surgery and the pseudoparalysis. Like I had mentioned, also severe deformity where you have a lot of posterior bone loss. Trying to return the socket alignment to a more normal alignment could cause a lot of loss in bone. In some of those patients, a reverse could be performed to try to not have to take out so much bone and return function to the patient. There are some other options that you could perform in a anatomical shoulder for that, so it's not always indicated, and inflammatory arthritis. So for all the benefits and the conditions that we can treat, there are always some complications. So infection risks in shoulder arthroplasty in most places is around 1%. It's not a very high risk, but it's a risk that does exist. It usually requires removal of the implants, IV antibiotics. It usually requires several weeks to a couple of months of IV antibiotics, and usually we're going to insert some kind of cement spacer as a temporary device to help hold the space so that in the future, if we need to reconstruct the joint, it can be done. All these joints, in order to get into the joint and do our reconstruction, we usually have to remove one of the big tendons in the rotator cuff, and we repair that back on. But if that tendon is to fail to heal or is to re-tear, it could cause some instability, which would mean dislocation of the joint. All these joints have metal parts that are usually fixed into the bone. More and more, they're fixed into the bone by having the bone grow into the device, into the metal. Sometimes we do use cement to hold the plastic like sockets into the bony glenoid. But all those are potential areas of loosening. If it gets loose, they can become painful. They can also destroy bone, and therefore they may need to have some kind of surgical correction. The plastic component can also wear. If there's wear and no loosening, it's fairly unusual in the shoulder to have to go back and take out the worn plastic and then put another one in, but that is something that can sometimes happen, especially more in the knees and the hips. Fractures, you can see an example here where the humerus broke below the stem. They can occur, especially with falls and when we've had replacements. The other thing to remember about a reverse, it can be difficult to revise. Like in this patient here, a revision might need to remove all of the stem. There can be some significant bone loss. It's also very thin, the bone, and might require bone grafting to try to get some bone to work with in the future. There's a lot of bone that's lost when we make that cut and put the socket in, and that's what can give us some issues. Also on the socket side, that's where most people have their problems, and that's where then most people usually will loosen. And again, it can be difficult to revise. You could use bone graft sometimes to increase the bone stock to be able to allow a second implant to be placed. So the anatomic total shoulders have a tendency to have better motion. This is usually a motion in internal rotation, like going up in the back. Patients with reverses sometimes will complain that they don't go up in the back high enough. The anatomic replacement seems to have less of that. They give good pain relief, they improve people's function. They're fairly rapid improvement, although, like I mentioned, we do repair a tendon in the front of the shoulder, and we kind of protect that for several weeks after a shoulder replacement to try to prevent further future complications. So the indications, why are we doing total shoulder arthroplasty? We're doing it for osteoarthritis. Wear and tear arthritis is usually the reason that we're doing most of these replacements. Here's a good example of a short stem with an anatomical replacement. You can really see where the plastic piece is. You can actually see that this is a pegged implant, and you can see some of the cement around the pegs. Avascular necrosis, that's when the head dies. There's lots of reasons for this to happen. Some people, when they get chemotherapy, this could happen in the shoulder. In a total shoulder, in an anatomical total shoulder is a good reconstruction, especially if both sides of the joint are affected, and that's what we usually see, both sides of the joint are affected. Sometimes in post-traumatic arthritis, an implant like this could be used to reconstruct the joint. In people with fractures down below here, the fact that this isn't a stem can make it easier to implant this type of device. Complications, so there's, again, just like for a reverse, there are infection complications, and we've kind of talked most about those latent infections that can be kind of difficult to tell if they're there versus an acute infection, which is the infections that we normally see. An acute infection is usually the incision's red, it's draining some fluid, it's usually very painful, people usually have fevers, and they don't feel good. Latent infections are slower, the wound can look very good, it can not necessarily drain, but people can complain of stiffness and pain, kind of vague complaints, but this progressively gets worse, and at one point we do a revision and sample the tissues to try to diagnose this type of infection. We put a spacer in and then treat it with IV antibiotics, and sometimes even for a long course of PO antibiotics, and then we can reconstruct the joint if we can eradicate that infection. There's loosening and wear, just like in a reverse, and instability, and this is an example of instability. The socket is here. The ball is kind of almost dislocated completely out of the socket, and it's because there was a tear in the subscapularis muscle, that muscle that we cut to allow us into the joint and perform our reconstruction. So the Ream and Run is the kind of a new type of arthroplasty, although it has been performed in different variations. This is made popular by the group at the University of Washington, and basically we're performing a resurfacing or a replacement of the ball part of the humerus, and then we're reaming the socket to try to allow for some scarred joint surface to form. We also try to reorient it a little bit so that we have more the joint working in a more normal fashion. The advantage of this is that there is no socket to get loose. So if there's no socket to get loose, we think that it may buy us some time and allow a patient to be more active, doing heavier type work, and then down in the future, once they start to fail this, or if their pain starts to return, then we can go back in with a smaller revision and just place a new plastic socket into the glenoid and allow to go back to pain-free, good function. So the advantages is most people will get good pain relief. It allows a higher activity level. It allows you to go back to weightlifting, and we kind of have eliminated, or at least temporarily tried to push back the need for the weak link in the system, the glenoid implant, to be placed. Its disadvantages: most people that have an anatomical total shoulder replacement, the pain relief comes fairly quickly. A lot of people that I have are already starting to wash their hair at 6 weeks, which means that they're getting good motion and good pain relief fairly quickly. On the Ream and Runs, we find that this is slower. It takes a few months for this to happen. It takes longer to get your motion back, and then it's slow to get the strength back. Once it comes back, though, the patients seem to be doing almost as well and seem to be able to tolerate at least fairly heavy work. Again, they might still require another component to be placed in the future. And some, if a patient had an implant on the humeral head that was no longer in production for we don't know what reason, we might have to still, even if all we had to do was replace the socket, we still might have to replace the humeral head component because it's out of production and we cannot get the right size socket. A lot of these total shoulders have a certain amount of mismatch between the radius of curvature of the socket and the ball, which means that they're not touching all the time. There's a little bit of sliding that has to be allowed for better function in the shoulder. We see this is one of the differences between a shoulder replacement and a hip replacement. So that if we cannot get a component that would have the right mismatch, we might have to change both components in order to reconstruct the joint. So the incidence of shoulder arthroplasty, it's increasing. So more and more shoulders are being done. There's somewhere about 50 to 60,000 plus procedures being done in the U.S. So it's becoming more common. I think this is mostly because people are doing well. They're telling people that they're doing well, and people are now considering having this done instead of just living with their pain. A lot of people in the past would tell me, it's just not worth doing it. I don't want to do the replacement. Now people come in and say, my friends have had this replacement. I want to have it. I'm having the same symptoms. And the results in general, no matter which one of these replacements that you're doing, they get good pain relief. They have improved mobility. One caveat on mobility is patients that come in very stiff have a tendency, even with the replacement, to be stiff. So the better your motion is pre-op, in general, the better your motion is after these replacements. And fortunately or unfortunately, it's true for the hips, the knees, and the shoulders. So if you come in with good mobility in general, we expect fairly good mobility. If you're extremely stiff, it will improve your motion some, but most people are still stiff. Most studies show excellent function, especially in patient-reported outcomes. Thank you, everybody, for listening. I hope this answered your questions on shoulder arthroplasty. If you have any questions, feel free to call us. Our phone number is 401-632-4520. There is a link that you can click on this video. You can also contact us or make an appointment online at universityorthopedics.com. We'll be happy to answer any questions.